This is 13th in the series of masterclass, which we started about 2 months back. And we find that a lot of people like these masterclasses because the topics have been very relevant and we had a wonderful speakers all through. So welcome again to ISG Masterclass. And in the series today, we have one very important clinical topic, that is functional dyspepsia. And how do you approach such patient if you encounter in an outpatient? This is a problem which all of us see almost every day in outpatient. You might be a physician, you might be a gastroenterologist, and these symptoms of functional dyspepsia are very, very common in our society. Therefore, we thought that we have to have a master class on this topic, which is this is quite relevant. And for this, we have a speaker, Dr. Usha Datta. She's a professor of gastroenterology at PGI MER Chandigarh. And with this, let me request Dr. Saraswat to welcome you and introduce the speaker and take towards the lecture. And also to introduce Dr. Jayanti, who kindly consented to be the moderator.
Thank you, Dr. Govind. Good morning. Once again, a great pleasure to welcome you back to the ISG Masterclass. A slight change this week has been that we have moved from a twice a week format now to weekly classes, and henceforth, hopefully we'll be seeing each other from 12 to 1 on Sundays for the next couple of months. Part of the program is already put up on the ISG and the Masterclass websites, and the remainder will be updated very shortly. It's a great pleasure to welcome Dr. Jayanti. Good afternoon, Dr. Jayanti. And from all of you know her. She's one of the most eminent teachers from the southern part of our country, and an old friend. I think we have been friends for almost 25 years, 25 years, Dr. Jayanti.
Yeah, more than that.
One of the most passionate teachers I've come across. One of the things that she is most interested in is teaching and passing on whatever experience all of us have gained to the newer generation of gastroenterologists. And I welcome Dr. Usha Datta. Usha is a professor of gastroenterology at the PGI Postgraduate Institute in Chandigarh, and also a very old friend, a person whose career I have followed closely from her days at the All India Institute, and then for the last 15 odd years or more, maybe 20 years now at Chandigarh. She's a consummate teacher also. Teaching, she's very methodical, systematic. She slowly takes you over the basic principles, and I think it's going to be a treat for all of you to listen to her speak on functional dyspepsia. As you know, dyspepsia not only is a very common condition, but over the years, the terminology that we have used, the semantics of and the meaning of these terms have been changing. And today, what we mean and what we understand about functional dyspepsia and how to approach and manage it is what is going to be the topic for her lecture for the next 45 minutes or so. So with these few words, I will request Dr. Usha to please start her presentation. Share the screen and let's get going.
Thank you, Dr. Govind and Dr. Saraswat, for inviting me to moderate. Over to Usha.
Thank you so much, ma'am, for joining us.
Thank you, Professor Saraswat. It was a very kind introduction, and thank you, Dr. Govind, for inviting me here for this masterclass. It's indeed a pleasure and privilege to be a part of ISG, and especially during this corona epidemic, we are still continuing our academics. That really speaks very highly of our intention to keep academics alive. Thank you for all your introductions. I'll now get along with this topic. Approach to dyspepsia. I have kept it as an Indian perspective for all our Indian audience. Dyspepsia is a Greek word for bad digestion. Symptoms localized to the epigastric region is considered as dyspepsia. So any patient coming with symptoms for more than 4 weeks in the form of upper abdominal pain, discomfort, nausea, vomiting, heartburn is considered to be dyspepsia. There are varying definitions. So this is the broad definition for dyspepsia. The prevalence worldwide is as high as 30%. and 5% of them seek consultations. It affects quality of life. It is associated with cost involvement for the patient as well as the healthcare setup, and it adds to a lot of healthcare burden. Fortunately, it is not associated with increased mortality. Cardinal symptoms, that is epigastric pain and epigastric burning, which may be associated with a meal, or it can be in an empty stomach. This is characterizes the epigastric pain syndrome. The postprandial fullness and early satiety characterizes the postprandial distress syndrome, and it is usually meal induced. Along with that, there can be associated symptoms in the form of bloating, belching, nausea, and vomiting. But usually nausea and vomiting is only mild or occasional. Significant vomiting means that you should look for other causes, which may be like gastric outlet obstruction or gastroparesis. So if we look at the epidemiology worldwide, in North America, it's about 30%. In England, it's about 40%. In the Scandinavian countries, about 28%. India is at about 30%. And Japan is about 24%. So it's more or less similar, 25 to 40% all across the world. The interesting thing is that I picked up, there are many studies on dyspepsia in India. I picked up 2 studies, which are the largest series in India. And one is rural based and one is urban based. The prevalence is about 20% in rural community, 30% in urban community. The most important thing is that the combination of postprandial distress syndrome and epigastric pain syndrome is far more common than any individual one, that is postprandial distress syndrome or epigastric pain syndrome. Postprandial distress syndrome is the second commonest form of dyspepsia. And about 4 to 14% have 30% have heartburn. Heartburn does not necessarily translate to GERD, but just symptoms of occasional heartburn may be present in a fair proportion of patients with dyspepsia. In a large study of IBS patients, 49% had associated dyspepsia. Now, what are the 3 terminologies of dyspepsia? First is uninvestigated dyspepsia. That means any patient coming to you for the first time with these symptoms. On history, examination, and investigations, we can then classify them as organic or functional. Organic usually comprises about 20 to 30%, and organic can be of GI causes or non-GI causes. Functional dyspepsia is the bulk, that is 70% is due to functional dyspepsia. Earlier on, the terminology was non-ulcer dyspepsia. Now, Rome 4 likes to call it disorders of brain-gut interaction. Now, among the organic causes of dyspepsia, let us see what are the GI causes. We are all gastroenterologists, so we are more interested in this component. H. pylori, peptic ulcer disease, and gastric cancer, these are all luminal causes of organic dyspepsia. Whereas pancreatic malignancy, pancreatic cancer, pancreatic insufficiency, gallstones, sphincter ovary dysfunction, biliary dyskinesia are the pancreaticobiliary causes of dyspepsia. So we need to rule them out. So when we take the history, it is important to see whether the symptoms are more on the right hypochondrium, the spectrum of nausea and vomiting being more significant. The symptoms are usually more severe. LFT abnormalities and ultrasound abnormalities go more in favor of a pancreaticobiliary dyspepsia. Now, there are non-GI causes of dyspepsia. We know we see a lot of patients of diabetes, hypothyroidism, organ failures, pregnancy, and medications. And a fair proportion of these patients have dyspepsia. That is about 70 to 80% of these people have dyspepsia. It is very important in our history to look for these causes of dyspepsia. So what is the Rome 4 criteria for functional dyspepsia? Dyspepsia is classified as epigastric pain syndrome or postprandial distress syndrome. The symptoms have to be bothersome. That means it has to affect the daily activity of the person. It should be of cognition for the patient. And the duration of symptoms should be minimum of 3 months. And the onset should be somewhere 6 months back. So indicating that it's a chronic problem. And it is important to note that in the postprandial distress syndrome, the symptoms have to be present at least 3 days in a week in the form of postprandial fullness or early satiety. Whereas epigastric pain syndrome and epigastric burning, even once a week qualifies as epigastric pain syndrome. And on endoscopy, there should be no structural disease which is identifiable. Just antral gastritis is not structural disease. Structural disease, I mean a stricture or a polyp or a malignancy or an ulcer, those are structural diseases. So when we look at the types of functional dyspepsia, we have basically postprandial distress syndrome occupying 38%, epigastric pain syndrome occupying 27%, and 35% an overlap between these two. And it is important to note that about 1/3 can have symptoms suggestive of GERD and 14% can have symptoms suggestive of irritable bowel syndrome. Now, what is the pathophysiology of dyspepsia? I've kept it very simple. It could be acid. Usually it is not that there's excess acid, but the acid is an injurious agent for the gut. So that perpetuates inflammation by increasing gut permeability and allowing toxins to get into the system. There would be dysmotility in the form of either decreased gastric emptying or lack of fundic relaxation. H. pylori, I will come to that in a greater detail as to how it has any role in dyspepsia. There is visceral hypersensitivity, which makes that these people, even with minimal gastric distension, have complaints of pain. There can be underlying psychiatric comorbidities in the form of anxiety, depression, or childhood abuse and stresses. Duodenal inflammation is coming up as a very important role in dyspepsia. In fact, increased duodenal eosinophils, increased duodenal permeability, increased IELs in the duodenum, chronic inflammation in the duodenum is an important pathogenetic factor which has been identified in the last couple of years. So how do we assess what is the cause of the severity of dyspepsia? There is a combination of tissue injury, either by infection, antibiotics, or NSAIDs. This in combination with the way we perceive this symptom, that is because of our stress, child abuse, depression, or anxiety, this translates into symptom severity. So it's a combination of these two. These are usually mild symptoms, but because of perception, it may be considered as moderate by the patient. So how do we quickly evaluate these patients? History, we take the symptoms, the severity, and the nature and the spectrum of symptoms. Whether there are any systemic illnesses, whether the patient is on any drugs such as NSAIDs, very important to take that history, aspirin, or any other antibiotics or any other drugs which can cause GI injury. Then the most important thing is to understand that dyspepsia is bad digestion. Patients are not able to digest. Diet in terms of timing, quantity, and quality of patients is very important to understand, because many people tend to skip their breakfast, have a very late night, heavy, fatty meal, spicy meal, because that is the time in the day that they're relaxed to have their meal. So this kind of a thing creates a problem with the GI system. GI system loses its rhythm. Next is GI infections in the form of a recent GI infection can precipitate post-infectious dyspepsia. GI infection could also be like an H. pylori acute infection which goes on into a chronic state. So a history for that should be taken. Also history of exposure to travel in the form of infections like Giardia and other organisms. Then also brief history about what is a kind of perceived stress and what are the alarm symptoms. So this is a very important part. I'll come to that in the next slide. Alarm symptoms is age more than 60 years in the Western parlance, more than 40 years in Korea and Japan and China. Presence of GI bleed, anemia, progressive dysphagia, odynophagia, persistent vomiting, weight loss which is unintentional, family history of gastric cancer and esophageal cancer, presence of a palpable lump, lymph node, or imaging abnormality, history of NSAID or aspirin use can all be associated with are called alarm symptoms. Presence of one increases the risk of finding an organic lesion. Presence of more than one increases the risk of organic lesions. So we should see whether it's just one symptom or a complex of symptoms. On examination, we quickly look for obesity or recent weight loss, pallor, icterus, cervical lymph nodes, acanthosis nigricans, abdominal tenderness or lump, and any features of hepatosplenomegaly or ascites, and any signs of systemic diseases. So what do we do as a baseline investigation in these patients? We first do an hemogram. If there's anemia or raised ESR, it suggests that there is possibility of any blood loss, ulcer disease, malignancy, or inflammation. We look at the renal function tests to look for any features of chronic kidney disease. Liver function test is important because it may give us an indication for pancreaticobiliary diseases, and thyroid function test in all these patients, especially to look for hypothyroidism. Blood sugars, if they are elevated, we know diabetes 80% can present with dyspepsia. Stool examination is a routine, especially in our country, to look for ovoparasite cyst, as well as occult blood and H. pylori antigen, to which I'll come to later. So these are the simple ways by which you can look for any gross pathology happening in the stomach. Ultrasound for stones, CVD dilatation, and pancreas. Sometimes it's difficult to pick up pancreatic lesions on ultrasound, but if there is a suspicion, then a CT scan. But otherwise, routinely, just a screening ultrasound is useful to pick up pancreaticobiliary diseases. Now comes the million-dollar question: who needs endoscopy? Definitely those with alarm symptoms need endoscopy. Now, what is the age cutoff for India? We do not have Indian guidelines for this purpose. There has been a lot of debate on this issue. So I will just take you through some key data across West India and Asia, the rest of Asia. Now, if you see the slide, it's very important to know that the amount of dyspepsia across the countries is very similar. The type of dyspepsia, India and the East have most often postprandial distress syndrome. H. pylori prevalence in India is high compared to similar to the East rather than the West. In the West, actually H. pylori prevalence is going down steadily because of improving socioeconomic status. But the thing which I want to draw your attention to is, though the incidence of gastric cancer in India is low, it's not as high as the East, but I think we are missing a lot of early gastric cancer. In the West, less than 1% of patients in less than 40 years are having early gastric cancer, whereas in India, 14% of our people are less than 40 years who are having early gastric cancer. So if you see, the 5-year survival of our gastric cancer is extremely low. That means we are missing a lot of early gastric cancer, and the best time to target that is at the age of 40. If we do an endoscopy in a patient with dyspepsia and look for early gastric cancer, maybe we may be saving a few more lives in our country. In Chennai, there was a large study in 3,432 upper GI endoscopies. 18% of the upper GI cancers were less than 45 years. So they found 43 years was the best cutoff for males and 38 years the best cutoff for females to pick up early gastric cancer. And also we have to understand that the way West has handled upper GI endoscopy is because of insurance issues, cost issues, biopsy processing issues and all that. But in India, it's also a single time visit to the specialist. There's easy access to endoscopy. Cost is not so prohibitive. It is usually out of pocket, so we don't need an insurance clearance for doing an endoscopy. And it's an opportunity to pick up early gastric cancer. However, it's a very common practice. I find patient has had already an endoscopy, you go ahead and repeat it, for which there is no rationale. So if the patient has had an endoscopy in the last 2 years, please do not repeat it unless the patient has had worsening of symptoms in any major way. The other thing is that endoscopy, what do we look for in endoscopy? You can, in the esophagus, start looking for esophagitis, erosions. You can look for hiatus hernia. You can look for fundic gastritis and atrophy in the fundus. You can look for gastric polyps. You can look for erosions, which are usually drug-induced, NSAID-induced, and again, erosive gastritis. You can have nodularity in the antrum, which is usually in children more due to H. pylori gastritis, or in adults, we quite often find this chronic atrophic gastritis. You can find a gastric ulcer. You can find linitis plastica, especially a patient with increased early satiety. There's decrease in the gastric available volume for distension. You quite often are very surprised when you find an advanced gastric cancer, but our aim for endoscopy is to pick up this early gastric cancer. This is one very important message I want to give in this talk, that our aim for doing endoscopy in dyspepsia should be to pick up early gastric cancer, RUT properly done, so that if this thing can be prevented from progressing, that is a success for us. So we should use NBI. We should use NBI to pick up H. pylori gastritis. Now, most of the people have scopes which have also NBI, and this is a pattern which we can see for early gastric cancer. There is a detailed lectures on NBI and how to use it for early gastric cancer. However, I don't have the time to go into that, but this should be a very important flagging when you see a patient with dyspepsia undergoing endoscopy. You may have a lot of excess gastric residue to suggest that there is gastric emptying issues, or you may find a pyloric stricture due to NSAIDs. And you may find duodenal erosions. This is also common in patients with H. pylori gastritis or NSAID-induced gastritis, or you may find nodularity in the duodenum. You may find evidence of celiac disease in the form of grooving, scalloping, and decreased fold height. You may find duodenal ulcers. In a large meta-analysis of 5,389 patients, 72% have normal endoscopy. That is what is expected. If in your center you are having more than that, that means we are doing unnecessary endoscopies. But 13% may have erosive gastritis, about 12% have ulcers, 1% has Barrett's. A very small percentage will have gastric cancer and esophageal cancer. I expect this rates to be higher in our country. Endoscopic biopsy in upper GI when the upper GI is normal. So many people argue, why should we do? Now that you are in, you should do it. That is by the Sydney protocol, updated Sydney protocol. 5 biopsies are better than 3 biopsies. So first we take it at the antrum, on the lesser curvature and the greater curvature, at the incisura, and at the mid body on both sides. If the patient has had PPI and has history of and there is evidence of CA stomach, then fundic biopsy will pick up H. pylori which has migrated to the fundus. RUT, it's important to use only validated kits. It is very important to understand that RUT is positive if there are more than 10 to the power 5 bacteria. So when patients are on PPI and we do an endoscopy, our H. pylori is suppressed and RUT will be false negative. So it is very important to stop PPI, antibiotics and bismuth minimum 2 to 4 weeks prior to endoscopy. And so, daycare endoscopies, quite often patients come in and they're on PPI and undergo endoscopy. At that time, RUT may not yield what it needs to yield. If the patient is very symptomatic, the patient can be switched to antacids and H2RA till the time he or she is waiting for endoscopy. Another caveat is that once we report at 30 minutes, and to say it is negative, we need to go to 24 hours before we declare it as negative. False negative, as I said, could be because of low H. pylori load. The room is very cold for the reaction, so temperature has to be adjusted. If there is intestinal metaplasia, gastric cancer, or GI bleed, you may have false negative. So chronic gastritis on biopsy, you may find just chronic inactive gastritis. This is the commonest biopsy report we get. But sometimes you may find activity, and especially when you have activity, you should look for H. pylori. So you may find H. pylori on HNE staining. You can do special stainings, but most of our pathologists are happy just doing HNE staining. You may find giardia in the duodenal biopsy. This is important. This slide is important because in duodenitis, you may have increased IEL, increased inflammation. So many patients with dyspepsia may have just increased duodenal inflammation, and you may have a lot of eosinophils also. You may find incidentally celiac disease also during endoscopy. So how do we approach the investigation? In a patient with uninvestigated dyspepsia, take a good history examination and baseline investigation as outlined. Rule out non-GI cause of dyspepsia. If there are alarm symptoms and the patient is more than 40 years in India, and if alarm symptoms are present, go ahead, do a prompt endoscopy, biopsy and RUT. If you find any lesion, accordingly you diagnose it as organic dyspepsia and treat. If there is no alarm symptom, patient is less than 40 years, go ahead and do a urea breath test or the stool antigen test. During the corona time, I'm not very sure whether we want breath tests to be done. So stool antigen is a good option. And if it is positive, we consider it as H. pylori associated dyspepsia. and we go ahead and treat. Now, if endoscopy is negative and stool antigen is negative on either end, if both are negative, it will be called as functional dyspepsia. So now we have a case scenario, a very common case scenario, 36-year-old man who has bothersome some postprandial fullness and epigastric pain for 6 months, no alarm symptoms, no comorbidities, no medications, hemoglobin is good. What should you do? So this is a very common thing in our OPD setting. I'm sure all of you see this day in and day out. If for this we need to understand what we do for H. pylori, because if you see dyspepsia and H. pylori, the Indian data, about 60% of our dyspeptics are having evidence of H. pylori by RUT or histology, 60% on stool antigen testing. Seroprevalence is also high, but it is only 10% more than the routine controls. And those who are H. pylori positive more often have severe dyspeptic symptoms, and treatment results in the form of eradication results in reduction of the symptom scores, and resolution of symptoms. If it resolves, then we call it H. pylori associated dyspepsia. Despite eradication, if the symptoms do not resolve, then it will be called H. pylori eradicated state and functional dyspepsia. So in India, this would be our best strategy for such a patient. You do a non-invasive test like stool antigen and urea breath test. Stool antigen is underutilized. It has a good sensitivity and specificity. Urea breath test also has a good sensitivity and specificity. So we should use these two more often to diagnose H. pylori in a non-invasive way. If there is indication for endoscopy, then you just go ahead and do an RUT and histopathology. That is sufficient. And as I already underlined, that PPI and antibiotics should be off. Otherwise, a negative RUT does not exclude H. pylori. So how do we go ahead with managing these patients who are having suspected H. pylori? Strategy for management: prompt endoscopy.
Do you want to take a break? Do you want to take a break this time?
Give me 2 seconds. I'm coming to a break slide. Give me just about 2-3 minutes. So strategy for management is prompt endoscopy in patients who are more than 40 years and are having alarm features. The strategy for management: test and treat for H. pylori, especially if age is less than 40, there are no alarm features, and this is actually a very cost-effective approach. Empirical treatment with just PPI delays the diagnosis, is not cost effective, and hence should not be our first line strategy in our country. There is a very nice network meta-analysis published recently on 15 RCTs, about 6,000 patients. And what it showed is that the test and the treat policy and prompt endoscopy are the way to go, and not empirical acid suppression. Because the test and treat policy has the lowest chance of endoscopy, and the prompt endoscopy strategy has the maximum patient satisfaction. So with this in mind, there is another large meta-analysis which has shown that if you eradicate H. pylori, you have number needed to treat is 14. The response rate for dyspepsia is about 10% better, and benefits overall outweigh the risk for anti-H. pylori therapy in patients with dyspepsia. I will, just before I go on to the break, I'll just share a recent study on Helicobacter pylori from Kashmir, where they had H. pylori prevalence in dyspepsia was 58%. Eradication with triple therapy, they achieved in about 70%. They documented healing of gastritis. There was symptom resolution in 60%, but 52% also in the placebo arm, so there was no significance. But at 12 months, there was again 43% had sustained symptomatic response, but in the placebo arm also it was 37%. So there was no additional symptomatic improvement despite healing of gastritis. So we should not expect magic with anti-H. pylori therapy, but it is indicated. So when and how to eradicate H. pylori? H. pylori gastric secretions and motor function, it affects the gastric secretion motor function. Small and significant benefit, it's cost effective. It helps in preventing subsequent peptic ulcer disease and malignancy. All guidelines recommend it, and ensure a 14-day treatment, standard regimes, compliance, and according to the local resistance pattern. So with this, I will give it a break right now, and then we will come further.
you, Dr. Usha, for that excellent presentation. We have quite a few questions from the audience. I'll address a few of them. One is about the heartburn. Would you like to consider that in the category of dyspepsia? Heartburn. There are at least two people, one Thirumal from Pondi and Dr. Anand from Chennai.
Yeah, it is important to consider heartburn is a symptom of dyspepsia, but to make a diagnosis of GERD, you need either a 24-hour pH monitoring on one side if you're doing a research study. Otherwise, from a clinical perspective, you need retrosternal burning or heartburn going on, which responds to PPI. 4 weeks of PPI therapy. So that is what the American College of Gastroenterology recommends, that we should have response to PPI. And in that situation, heartburn, GERD is a separate disease, dyspepsia is a separate disease. There is an overlap. And if a patient of dyspepsia has occasional heartburn, we just treat it as dyspepsia. If there's only symptoms of retrosternal burning, heartburn, then double dose PPI for 8 weeks is a better strategy. If it is only dyspepsia with heartburn, just once a day dose PPI is a better strategy.
There's one other question by Dr. Toshniwal from Powai. This bloat is a common problem which we encounter in our day-to-day practice. So he says if it is within half an hour, you think it is gastric in origin, and if it's beyond half an hour, it is from the small intestine. And therefore, is it small intestinal bacterial overgrowth related? So just by the, like immediate bloat versus a delayed bloat. Does it make any sense in dyspepsia?
I think what I gathered from this question is that the timing of bloating. Yeah. So usually just after a meal, if you are feeling bloated, that is usually related to gastric bloating. But patients with small bowel bacterial overgrowth can have even a delayed bloating, but quite often there is a lot of overlap. It is difficult to just differentiate on the timing per se.
Sure. One other question by Dr. Sunil from Trivandrum. When the treatment for dyspepsia is either a use of prokinetic or a use of a PPI, is there a need to actually classify patients with dyspepsia or an anti-H. pylori treatment? So is there any need at all for classifying dyspepsia?
It is very important to classify dyspepsia, because I will come in my subsequent slide how the classification helps in choosing the therapy, and the prognosis of these patients are different. So it is important that we classify dyspepsia and proceed in a systematic way.
So you still believe classification is important? Yeah?
Yes.
Dr. Ajay from Rishikesh, gastroparesis is a common problem. So in what category would that fit in with functional dyspepsia?
Yeah, gastroparesis has to be excluded before we make a diagnosis of functional dyspepsia. In functional dyspepsia, you may have a delayed gastric emptying time in about 40% of patients. But as I said earlier, predominant nausea, recurrent vomiting, and on endoscopy, if you find a lot of residue, you know that there is significant impairment in gastric motor function. In such situations, you should do a solid gastric emptying time and assess whether at 4 hours more than 90% has emptied the stomach. If it hasn't, that means there is a motor abnormality of the stomach, which the commonest setting is diabetes. And if it is there, then there are various ways to treat there. There you need prokinetics, better blood sugar control, and also now people have started doing third space endoscopy to relieve the pylorospasm.
A question from Dr. Pranya from Dibrugarh. Is NBI always necessary to rule out in all patients while doing endoscopy in dyspepsia? And also the same question is by Dr. Singh from Indore. Is NBI always mandatory while doing an evaluation for patients with dyspepsia?
That's a very pertinent question. Most of our endoscopes nowadays do have NBI. So it is a very simple switch of the button. Minimum at the antrum and the body, it takes an additional 4-5 minutes to completely examine. And as I said, it is better to do a single good endoscopy rather than multiple endoscopies which just show some antral gastritis. So NBI should be an added armamentarium in our country in those who are minimum 40 to 70, 80 years of age, 40 years plus age, we should carefully look for early gastric cancer. Our yield may be low, but definitely we will reduce our advanced cancer mortality.
So you do recommend NBI. I think before we go to the, as you continue with the session, one question from Nepal by Dr. Karki. He says that what is the reason for the H. pylori migration towards the fundus in patients with the dyspepsia?
H. pylori likes a lot of acid. So there is a lot of acid in the antrum. So once there is antral gastritis and there is atrophy and there's pangastritis, the amount of acid production in the stomach goes down. The only part which still continues to produce the acid is the fundus, which has the parietal cells. So the H. pylori goes and sits there in the fundus. So whenever H. pylori migrates there, that's why you need to do fundic biopsy to pick this up.
There are a lot of questions on treatment. Dr. Govind, you would like to, or can she continue?
We can go with the lecture and then we come back again.
Yeah. Dr. Usha, please continue.
Okay. Can I?
Yeah, full screen. You make it full screen.
Is it visible?
Yes, go ahead, I think, Usha. We are fine seeing the full screen.
Okay, just 1 second. Yeah, so what H. pylori treatment regimes do we have? There's a lot of data on that. I cannot go into all of that. The standard triple therapy, that is PPI, amoxicillin, clarithromycin. PPI 40 milligram BD of esomeprazole or rabeprazole 20 milligram BD, plus amoxicillin 1 gram BD, clarithromycin 500 milligram BD in the first week, and this gets continued into the second week. So this is called the standard triple therapy. It has about 80% success rate. People are not happy with this now because there is increasing resistance in our country to clarithromycin. So we need to substitute this by either levofloxacin or add a fourth drug, that is a bismuth, to make it more effective in our country. The other additional regimes which have come, out of which I like the concomitant therapy because it is simple. 14-day therapy of 4 drugs. So first week and second week is the same. It's easy to explain and it has a good efficacy rate. So concomitant therapy has PPI, amoxicillin, metronidazole and clarithromycin. In India, again, metronidazole has very high resistance, so we have to substitute it by tetracycline or by bismuth. So this is a 2-week therapy. Sequential therapy and hybrid therapy, I find it sometimes difficult to explain to the patients. So it's 2 drugs in the first week and 3 drugs in the second week, or 2 drugs in the first week and 4 drugs in the second week with near equal efficacy. Recently, vonoprazan-based regimes have been used in Japan. It has not yet got introduced into India. High-dose amoxicillin-based regimes have also found to be effective. Levoflox and bismuth-based regime should be the way we go in our country. So how do you follow up a patient after H. pylori? You give them treatment for 2 weeks. After 2 weeks, you give them PPI for 2 weeks, BD dose. And then after that, no drugs for 2 weeks. And then test for eradication. Eradication can be tested by urea bread test or H. pylori stool antigen. And we do an upper GI if there was a gastric ulcer, because we always want to exclude a malignant gastric ulcer. So this was the scheduled break time. We have already braked, so we'll go ahead. So how do we have a goal-directed therapy in functional dyspepsia? And as I said, we already discussed on the role of anti-H. pylori therapy. For acid, we have PPI, H2RAs, and antacid on an SOS basis. For dysmotility, we have prokinetic agents. For hypersensitivity, tricyclic antidepressants are very useful and they are underutilized in our country. A very small dose, 25 milligram thrice a day of tricyclic antidepressants are very useful. This is not as an antidepressant, but it is as a modulator of the visceral function. In psychiatric comorbidities, definite depression or psychosis or depression or psychosis, we should try full dose of tricyclic antidepressant, SSRI and psychotherapy, which is found to be effective. Increasing role of using antihistaminics in duodenal inflammation, seeing a lot of eosinophils, especially in children, it has been found to be useful. So we have a case scenario for 45-year-old lady with postprandial fullness, which is bothersome, early satiety for 6 months. So obviously she gets classified as postprandial distress syndrome, functional dyspepsia. We have to exclude any organic cause. There were no alarm symptoms, no medications, no comorbidities. All the workup looks normal. You have done, patient has had an endoscopy done outside, that does not show any structural disease. RUT is also negative. How do we treat? So this is our classical functional dyspepsia situation, which we have to treat, and we'll go through that in a stepwise fashion. So dyspepsia, alarm negative, HP negative. Now that becomes functional dyspepsia. Now we see whether it's epigastric pain syndrome or the postprandial distress syndrome. So the first important thing is to emphasize to the patient that we are entering into a partnership to get the patient's stomach all right or gut all right. So unless we enter into a partnership program with the patient, just giving drug therapy will fail. So we have to understand dietary interventions, lifestyle interventions, and reassurance, because this has 30% effect, that is placebo effect. And diet and lifestyle also improves patient satisfaction. So this is the cornerstone of treatment of functional dyspepsia, to which we will add a few drugs. If it is epigastric pain syndrome, empirical PPI once a day for 8 weeks. And if it is postprandial distress syndrome, the West recommends PPI, the East recommends prokinetics. So there can be a combination of PPI and prokinetics for 4 to 8 weeks. Then we assess at the end of 8 weeks. If there is response, we stop. We do not continue beyond that. This is another problem in our country. Most of our patients go on taking PPI over the counter. So it's very important at 8 weeks to bring PPI to a stop. And you shift it to H2RA or antacids or something like that, but not continue that endlessly. If at the end of 8 weeks patient doesn't show response, that is the time to check on psychotherapy, add tricyclic antidepressant, look at certain combinations and complementary therapy, re-emphasize diet and lifestyle and reassurance. So this slide summarizes how we should manage our patients with functional dyspepsia. So anti-secretory drugs, what is the rationale? The acid is not in excess in patients with functional dyspepsia. However, the duodenum is very sensitive to acid. Acid also induces gastric dysmotility. There's an impaired gastric clearance because the bicarbonate production from the duodenum is low. And as I said earlier, there is a problem with the duodenal mucosa. And acid, when you give anti-acid suppressants, it also suppresses H. pylori, and the number needed to treat is 9. So there is sufficient rationale to give anti-secretory therapy in the form of PPI or H2RAs. So in a large meta-analysis in about 8,000 patients, PPI definitely scored over placebo, number needed to treat being 13. And PPI was equivalent to H2RA in this meta-analysis. Prokinetics also has been shown to be beneficial, but number needed to treat is 20. PPI plus prokinetic added very little benefit. So really combining these two, which is the usual practice, may not be scientifically sufficiently rational. So this is according to the Cochrane meta-analysis done recently. Antacids H2RA in functional dyspepsia, again, it has very good efficacy. Number needed to treat is 7, but these are all old studies with some publication bias and heterogeneity. So this can be used as the second line therapy after the primary symptoms have been suppressed with PPI. The important thing, as I said, in India, where we get PPI over the counter, in the West, you can get it only as a prescription drug. And all this PPI causes a lot of problems in our human body system, especially it increases bacterial overgrowth, atrophic gastritis, interstitial nephritis, gallbladder dysfunction, neutrophilic dysfunction, hip fractures, and megaloblastic anemia. So we should monitor these patients for the same and not continue long-standing PPI. So the final word in PPI and H2RA is PPI is better than H2RA, H2RA is better than placebo in the initial treatment. However, in the maintenance phase, PPI is equal to H2RA. And standard dose is only once a day. In EPS patients benefit more from PPI than the postprandial distress syndrome, but postprandial distress syndrome also benefit from PPI. 8-week therapy is better than 4 weeks. If there is no response, you stop at 8 weeks. If there is improvement, you taper off after 8 weeks. And H2RA antacids, as I said, on an SOS basis. The benefits are there, it's marginal. So prolonging it beyond 8 weeks does not have any rationale. So no empirical anti-secretory therapy, as I highlighted before. Prokinetics, again, as I said, there is a problem with the gastric motility, gastroduodenal coordination, fundic accommodation, and hence there is a role rationale for prokinetics, and also the number needed to treat is 7. The disadvantage is that there are lots of side effects, so it cannot be given for a prolonged period of time. So I will not go into the details of these mechanism of action of various prokinetics. All that I will say is that we have metoclopramide, which we do not use on a regular basis because of its extrapyramidal side effects. Domperidone is used fairly often in our country because it has less extrapyramidal side effects. 10 milligram thrice a day or sustained release tablets can be given. Levosulfuride 25 milligram thrice a day has been found to be useful, and it also decreases the gastric sensitivity. Etopride has also been shown to be beneficial in associated GERD symptoms in 50 milligram thrice a day dose. Acoshamide has now come into Indian market, 100 milligram thrice a day, which promotes fundic relaxation. So prokinetics, again, number needed to treat is 7. It has fair good efficacy, should be tried in patients with significant postprandial distress syndrome like symptoms. Acoshamide, as I said, is an oral prokinetic agent introduced in Japan in 2013 and now has come into India, but the cost of therapy is fairly high for 4 weeks. Number needed to treat is 20. So in acoshamide, what it does is it helps in this fundic relaxation. Otherwise, the stomach feels very full and bloated. So it helps in the antral peristalsis, it helps in antroduodenal coordination, and helps in fundic relaxation. So this is a scintigraphy which has shown that after treatment, you find that the fundus is now distending and accommodating more food, so less of satiety issues in these patients. And all these symptom scores are better in the group with acoshamide compared to placebo. So then there is this entity of refractory functional dyspepsia. That means you're given treatment for 8 weeks, patient does not respond. Whether it was PPI or PPI plus prokinetic or only prokinetic, patient has not shown good response. So the second line therapy, as I said, is tricyclic antidepressants and psychotherapy. You do an upper GI endoscopy if it has not been done earlier. It was the test and treat arm. Then you do an upper GI endoscopy. Otherwise, if it has already been done, no role of repeating it. Do an ultrasound if you're suspecting a pancreaticobiliary cause. Look for other causes. Reassurance, lifestyle, and dietary modification has to be re-emphasized. So as I said, imipramine, 25 milligram at bedtime for 2 weeks, and then 50 milligram at bedtime for 10 weeks has been shown to have better efficacy than placebo and has good response rate of about 64%. However, there are some adverse effects, so patients tend to discontinue it. It is a useful drug to try. Psychotropic drugs have also benefit, and the number needed to treat is 6. So in patients with definite depression or anxiety, in those group of patients, you can give these therapies either yourself or in combination with discussion with your psychiatric colleagues. Very important to understand that response rate with placebo is as high as 30 to 40%. That's why most studies need very large numbers to do any drug trial, because the response rate in the placebo arm is about 40%. There is no systematic review, but this is something which we have to give in the form of reassurance and some medications to these patients so that they feel better. So this is a table which summarizes what is the efficacy of H. pylori eradication over placebo, 9% additional benefit, H2RA 20% additional benefit, PPI 25% additional benefit, TCA 26% additional benefit, etopride 10% additional benefit, acoshamide 11% additional benefit, and domperidone 29% additional benefit. So this table summarizes the efficacy over and above placebo. So we know that there is only limited efficacy of this drug, so we should not expect any magic miracle with these drugs. So we should combine it with other forms like diet, reassurance, and lifestyle modifications. So there are non-pharmacological therapies, which I said is placebo, psychotherapy, electrical stimulation, medical food, GFD. Many patients I find are intolerant to GFD, so they have non-celiac gluten sensitivity. In them, if you exclude wheat, these patients tend to do better. So for the initial 4 weeks, if we avoid gluten, these patients tend to do better. So what is the overall prognosis? The natural history is chronic and fluctuating. There's no effect on survival. Symptoms are persistent in about 20%. They resolve in about 50%, but fluctuate in about 30%. So 70% are going to go on like this up and down throughout their course of illness. So diet should be small, frequent meals, increase fluid, increase fiber, increase fruits, decrease oil, decrease overeating, especially at night time. Avoid odd time meals. Avoid skipping meals. Avoid skipping breakfast and then having a very late night heavy meal. Stop smoking. Decrease your spices. Decrease caffeine intake. Avoid NSAIDs. Make your lifestyle changes in the form of increasing activity and better sleep. So the treatment is no single strategy. We do not have no single drug is effective. Pathophysiology is too many mechanisms. Symptom based is not always effective. So there is no single best treatment. It has to be either strategy based, pathophysiology based, or symptom based. You have to individualize according to the patient in front of you. So in a simplified approach, dyspepsia, alarm symptom, prompt endoscopy, look for H. pylori, look for any lesions, look for early gastric cancer. Dyspepsia, no alarm symptoms in a high prevalence HP zone like India, test and treat strategy and confirm eradication. If there is dyspepsia, no alarm, no H. pylori, see whether it's epigastric pain syndrome or postprandial distress syndrome, re-emphasize diet, lifestyle, and reassurance. Empirical PPI for 8 weeks for this. In this empirical PPI with or without prokinetic for 8 weeks. No response, try tricyclic antidepressant, look for psychotherapy and other complementary therapy, and re-look at the diet, lifestyle, and reassurance. So what are the take-home messages? Dyspepsia is common and it's a vexing problem for the patient and the physician. 70% of the dyspepsia is functional dyspepsia. Look for associated GERD and IBS because that will help you fine-tune the management of these patients. A large number of patients with dyspepsia I find also have some constipation. So if you give some fiber supplements, these patients start improving, they feel better. Carefully rule out organic causes because you get only one chance in that patient who's coming to you to rule it out. Individualize your approach depending on the socioeconomic status of the patient's intelligence, patient's interest in his own healthcare. So individualize it and see if he is likely to come back to you or not if you call him. Prompt upper GI endoscopy if there's an alarm symptom. During endoscopy, it is not just an in and out endoscopy. Look carefully for H. pylori, look carefully for early gastric cancer, use NBI if you can. And if the patient does not have alarm symptom, you test and treat for H. pylori. You test it with urea breath test or stool antigen test. And if H. pylori is positive, you treat. If there is epigastric pain syndrome, PPI OD dose for 8 weeks and then stop. Postprandial distress syndrome, PPI plus minus prokinetics for 8 weeks and stop. If the patient still has ongoing symptoms, try tricyclic antidepressants and make lifestyle modifications. Avoid empirical long-term PPI therapy, which is a big problem in our country. Diet, lifestyle, and reassurance are cornerstones for this. Thank you.
Well, thank you, Dr. Usha, and excellent coverage of this extensive topic, and you've dealt with a lot of, you've generated a lot of questions as a part of your talk. I think the number of questions is about 167, 68, the number is crossed, pushing 170. So what I'll do is I'll take about the next 7-8 minutes, some of the important questions that I feel that I've been able to screen out. The first one of these questions is more to do with the initial part of your talk about definition and what to call dyspepsia. There is a question from Dr. Arun in Indore and Dr. Balaji from Bangalore about how do you label the subset of patients in whom the symptom duration is less than 3 months, 2.5 months of functional dyspepsia symptoms? And in continuation, Dr. Tirumal from Puducherry wants to know, isn't 4 weeks of symptoms enough to call it functional dyspepsia? Why do we have to wait for 12 weeks?
Yeah, very important practical questions, because patients come to you with 3 weeks or 4 weeks of symptoms. What do we call them? So usually if there are short duration symptoms, we expect that these patients may have had an acute insult in the form of a recent GI infection or a recent NSAID use or a recent spicy meals and dietary indiscretions. So we expect that these things would settle down. These definitions are usually made because for a research study, otherwise we need some standard definition before we put all these patients together. So that is why this thing of 4 weeks for clinical purposes and 3 months for functional dyspepsia has been a terminology which Rome 4 has used. So, in fact, the American College of Gastroenterology for practical definition, as well as the NICE guidelines, say just 4 weeks of upper GI symptoms is dyspepsia. In fact, American College of Gastroenterology says only EPS for 4 weeks is sufficient to call it dyspepsia. So,
Just
I
to
hope that
interrupt,
answered this
You're
question.
happy with 4 weeks?
Yeah, I'm happy with 4 weeks.
Dr. Usha, can you stop sharing your screen so we
Yeah,
can
sure.
have gallery view?
Yeah, sure. Yeah.
Right. Okay. Okay. I think regarding treatment, there are a whole lot of questions and testing and treatment. Dr. Siddhesh from Jaipur and Dr. Vimal from Rajkot want to know, most commercial kits of contain only 1500 milligrams of amoxicillin. So since you've talked about 1 gram twice daily, should 500 milligrams of amox be added in addition? And in continuation, how about adding probiotics, because many people get diarrhea with this problem? And Vimal also feels that adding probiotic might improve response in people with who are being given this anti-H. pylori treatment. So what do you think?
Yes, I think these two are pertinent questions. The only thing I didn't go into the detail of anti-H. pylori therapy because the focus of this talk was dyspepsia. I agree that most of the kits in India is only 750 milligram of amoxicillin. So what I do is I use a kit and add 250 milligrams morning, evening along with the amoxicillin. And I tell the patient which one is the amoxicillin capsule so that he clubs that 250 with the amoxicillin capsule when he's having it. Definitely, in fact, now in Vietnam, Malaysia, Japan, they have gone to higher doses of amoxicillin, 1 gram thrice a day, to show better efficacy. Vonoprazole plus high dose amoxicillin has been shown to have very good efficacy. So definitely 750 milligram amoxicillin is out. We have to have minimum 1 gram BD. And regarding the second question of probiotic, this is common.
Yeah,
That patients with this is common that patients on amoxicillin and clarithromycin tend to develop dysbiosis. So quite often what I do is I give 2 weeks of therapy with the antibiotic, and after that add probiotic for the next 2 weeks. So that helps in restoring the gut barrier rather than giving antibiotics and probiotics together. And I ask them to take a lot of curd during that period.
Okay. Now, I think regarding the stool antigen testing for H. pylori, and in regard to the test and treat policy, Dr. Balasubramaniam from Chennai wanted to know how expensive is the stool antigen test. And Dr. Rishi from Ahmedabad says that in a country like India with high prevalence of H. pylori, is it really useful to test stool antigen for H. pylori?
Yeah, the answer to that is that it's very important to understand that we don't use stool antigen very effectively in our country. Many countries use stool antigen very effectively. Only thing is we have to use validated stool antigen tests. I tried one Russian kit, it didn't work in our country, it did not get validated. So if you send it to a private lab, obviously it is expensive, about say 1,000 or 2,000 depending on how they charge. But actually the ELISA kits are not very expensive if you do it in your own setup. ELISA kit works out to be about 200 rupees per test. So it is not a very expensive test. Only thing, it should be validated in your setup so that your strains are similar which you're looking at. You had one more question apart from the stool antigen?
The cost, you mentioned the cost, and then whether because of the high prevalence of H. pylori, stool antigen testing strategy, is it really useful in India?
Yeah, it is useful because serology does not tell you active infection. Urea breath test, you again need a system to pick up the urea breath test. And nowadays, there is a problem with availability of urea breath test at various centers. So stool antigen is a simple test, should be developed. And along with the stool, you can do, occult blood, giardia. And nowadays, there are, blanket stool screening tests available for giardia antigen, H. pylori antigen, so that in one go you can look at all these things. I think as gastroenterologists, we shy away from getting stool examination done very frequently.
I mean, in continuation with this, what they were saying was that what Dr. Vishal from Mumbai and Dr. Ankit from Kolkata had the question that before antigen testing, should we stop antibiotic, or what is the effect of recent antibiotic and PPI consumption on stool antigen test positivity?
Yeah, very, very important question. PPI should be stopped for minimum 2 weeks, antibiotics for minimum 4 weeks.
Right. So these will have an impact on the stool antigen testing. Similarly, antibody testing, what are your thoughts on antibody testing for H. pylori? The question is from Dr. Vimal in Rajkot. Rapid antibody card tests are available. Should they be used in routine practice? Should that help people to avoid endoscopy? And can that be a basis for treating people for H. pylori if your rapid antibody test is positive?
Again, a very pertinent question for our country. In India, because our H. pylori prevalence by serology would be about 70 to 80%, it does not tell us active infection or past infection. So if the patient has never had anti-H. pylori therapy, for the first time he comes for test and treat policy, in the West, they have used antibody kits, rapid in-house test, rapid office-based test. So it is a good strategy, but in our country, it is not, we can still use it if it is the first time strategy and the patient's never received anti-H. pylori therapy. But for eradication, it is not a good test.
Right. So, and again, Vimal from Rajkot, his question is that should we routinely test after H. pylori treatment for eradication? And if so, what should be the best test? Repeat endoscopy or some other test would be useful for eradication confirmation?
Absolutely, we should test for eradication because we know that our efficacy of our regimes is only about 80%. So we should test for eradication. So the way to test it, 2 weeks of anti-H. pylori therapy, no longer 7 days, 10 days. So 2 weeks of therapy, 2 weeks of BD PPI, and then 2 weeks off all drugs. Then after that, either do a stool antigen test or do a urea breath test. If the patient had a gastric ulcer, you have to anyway go in for an endoscopy. At that time, you can repeat an RUT and histopathology. Otherwise, a non-invasive test is the best way, and all people should be tested for eradication.
Right. So in this continuation, because treatment related, there are a lot of queries. Dr. Bridge from Shimla says that, is it really worth treating H. pylori in India if there is no peptic ulcer, given that we have had a negative study in terms of from the Kashmir study that you yourself quoted just now? What do you think? Is it really worthwhile treating? A rather sweeping question, but still, it's a thought in many minds.
Yeah, very important question. It is relevant. There's been a lot of debate on this issue. Japan, Taiwan, China do actually screen people in the community for H. pylori and eradicate. Why? In order to reduce CA stomach incidence. So that is their strategy. We cannot go there, but minimum the patients who are coming from the community with dyspepsia to us, if they have H. pylori, we should detect and treat so that we minimum reduce the incidence in that subgroup of people. And we do not know, many of our patients, maybe dying of gastric cancer at home, we do not know. So we are underestimating gastric cancer. We may not have it as high as Japan and China, but also not as low as what we are seeing. So we should test and treat. And there was an earlier concern about recurrence and recrudescence. So recurrence of H. pylori infection was a problem that we will get reinfected. But I think with improving water and food hygiene standards, the chances of reinfection are actually low.
Right. I think the last few questions before I ask Dr. Jayanti to, she's also got a set of questions waiting for you. Dr. Pallavi from New Delhi and Dr. Gautam from Chennai want to know that they have experienced people with documented eradication within a few months coming back with a recurrence of infection. Now recrudescence or recurrence is not really being looked at, but they have a recurrent infection with symptoms. How many times should you treat for urea breath test? And if H. pylori or breath test, rapid test is positive, then should they go ahead and treat with second line drugs if people have recurred, assuming resistance? How do you go about this situation?
Yeah, so what we do is first line, we give first line triple therapy. That doesn't work. The patient again has RUT positive or breath test positive. Such a patient should be given 4-drug regime, with bismuth based 4-drug regime, and maybe there is clarithromycin resistance, so levoflox, bismuth, amoxicillin, and PPI. So 4 drugs for 2 weeks. After that, again check for eradication. If that has not happened, then is the time when you have to actually culture or go into other regimes like vonoprazole plus amoxicillin or high dose amoxicillin, uh, rifabutin. So there are these things become third line therapy. So that apart, definitely if the patient has recurrence after 8 weeks, he should be retreated with a better regime for another 2.
I mean, Dr. Gautam's question was about how many times would you treat if a person has recurrent infections? And again, the question would be each time you are treating and you are not actually testing for resistance, has the regime got to change?
Yes, because that is what I said. After for second time you treat and the patient again has a recurrence, he needs to be referred to a center where you can actually culture the H. pylori and assess the resistance pattern. Maybe he is resistant to clarithromycin and amoxicillin, so then you have to look for other
But
options.
you would be happy treating them repeatedly, 3 times, 4 times, multiple times if
It has to be individualized. Maybe there is a problem of compliance. Maybe this is a particularly very resistant H. pylori. Maybe we have to assess the risk, baseline risk for gastric cancer in that patient, and see whether probiotics can help, see what is the trigger in this particular patient. So
Right.
that has to be individualized.
Okay, thank you. I think Dr. Jayanti, I hope they would have some questions.
There are quite a few questions, but I'll address 3 or 4 of them.
110.
Dr. Yadav from Indore, in the current COVID pandemic, where do you think endoscopy would play a role in evaluation of patients with dyspepsia?
Yeah,
And
very important.
and do you think lifestyle modification would be the way forward before we evaluate these patients? This is a question from Dr. Yadav from Indore.
Yes, I agree with Dr. Yadav that during this COVID pandemic, endoscopy is not the option we have for these patients. So that is why either stool antigen test may be the only practical option. If not, we can now, go back on serology. If the patient has a lot of dyspeptic symptoms, has never received anti-H. pylori therapy, we can use serology for this COVID epidemic period. We do not use breath test, and we do not use upper GI endoscopy for diagnosis of H. pylori.
The other question is from Dr. Sanjeev Hubli and Dr. Pallavi. In the current social media telling a lot about H2RA and its problems related to that, where does it stand in management of patients with dyspepsia?
H2RA has been found to be very effective in studies in Japan, Korea, and China. They usually use a lot of H2RA, and we also used to use a lot of H2RA earlier on. I remember even now I give famotidine and Zintac for chronic maintenance therapy. I don't put patients on chronic PPI. So H2RA is very cheap. Famotidine is 40 paisa and Zintac is less than a rupee. So we should use these things more often in mild symptoms and not give PPI for these symptoms.
Okay.
And regarding the H2RA controversy, I think that has more or less got sorted out. That risk of increased malignancy is actually only for a particular, process, chemical process in that. So the famotidine, Zintac that we use and the famotidine that we use is safe. The famotidine is safe, yeah.
There are several questions on Welch phenomenon. So can you just address that? It's a common problem in day-to-day practice, aerophagia, Welch phenomenon. Where does it fit in dyspepsia? And maybe just 1 or 2 words on management.
Yeah, the Rome 4 had taken out belching and this belch phenomenon out of dyspepsia, functional dyspepsia, saying that any patient with dyspepsia who has this belching, repeated aerophagy and belching, you first rule that out and take it as a functional esophageal disorder rather than a dyspepsia related thing. So quite often these patients are very anxious. If you see these patients who are belching, they have a lot of aerophagy and they're belching. So if you reassure them and explain to them the whole process, that belching reduces with time. And along with that, H2RA can help if it is just an isolated belching. And
And one last question from Rishabh Gupta from Jaipur. Any role of intragastric manometry in functional dyspepsia, especially the postprandial distress and gastroparesis? Intragastric manometry.
Intragastric manometry is practically a time-consuming thing, can be used for research purposes, but for practical patient care purposes, it is not very useful. What we do is in patients with a lot of postprandial distress syndrome where we expect delayed gastric emptying, we do an idli-based gastric emptying time, where we have our own indigenous method. We use Gits ka idli packet. To that we add technetium, and then we bake the idli like how routinely idli is made and give it to the patient. 2 idlis with a glass of water, and that technetium is followed up for about 4 hours. So if more than 90% empties in 4 hours, you know that the gastric emptying time is good. If it is not, then these are the patients who may benefit with prokinetics. So we can switch prokinetics, give domperidone. If patient stops responding, then change to other prokinetic, because there is a component of tachyphylaxis with these prokinetics.
One final question from Calcutta, Dr. Anshuman Singh. In pregnancy with dyspepsia, you recommend H2RA or a PPI?
In pregnancy with dyspepsia, if the dyspepsia is significant, then first of all, I usually reassure patients that it is related to pregnancy and it will subside. If it is bothersome and it is troubling the patient, that is the time you need. Omeprazole is a class B agent, so we have to be careful when we prescribe. PPI can be given in severe symptoms. Otherwise, H2RA is a good option in these patients. Antacids, head and elevation, lifestyle changes, all those are more useful in this patient. During pregnancy, we minimize drug use.
Thank you, Dr. Usha. Over to Dr. Govind and Dr. Saraswat. Dr. Govind, you have to unmute.
Govind, unmute, please.
Questions which I want to highlight. One question is, a person asked that, would you investigate for celiac disease in patient with dyspepsia? And yes, please.
Yeah, celiac is Govind's forte area. As far as celiac disease, any patient who is having dyspepsia and also having some diarrhea, anemia, weight loss, some features of malabsorption, in such kind of situation, definitely we should look for celiac disease. And it's a very simple test, IgA-TTG. And in Govind's study also, they have shown 1% of Indians are having celiac disease, antibody positive. So it is a good strategy in patients with dyspepsia, especially in North India. When I see patients, very common to see a lot of celiac disease. So in them, we do an IgA-TTG as a routine purpose. And during endoscopy, I look at the duodenum for any grooving, scalloping, mosaic pattern.
Yes, truly. So, Dr. Dilavari, I wanted to ask one question, that the practice of doing stool test for parasite, most gastro don't do that. So, do you want to say something on that?
It's nice to hear that Dr. Dilavari is sitting and hearing a lecture on dyspepsia. Thank you, sir. Stool test is underutilized because, it is unpleasant to tell the patient, then the patient gives the lab is also not very interested. But I think, things are moving from Giardia on just microscopy to Giardia antigen-based test. So in stool, if we go to antigen-based test, we will have better sensitivity, better pickup, and more reliable results than observer-dependent, search for Giardia and all these things. I remember as an undergraduate reading a book of Chatterjee on parasitology, and then I realized ultimately you have to give albendazole 400 milligram one and another repeat after 2 weeks. Why understand all the life cycles of everything? But I think minimum with a single stool test with antigens may be a useful thing in our country.
And one last question I want to ask is, Dr. Bhavesh from Lucknow wanted to know the duodenal eosinophilia. How does it affect symptoms, and what practice do we change? Do we ask our pathologist once we send biopsy? Also, the two questions: once you do endoscopy, should you get duodenal biopsy to look for duodenal syphilia? And if you find, so you ask a pathologist to find for it, and then if you find, what do you do?
Yeah, very important and pertinent question. In fact, in the latest review in Nature, Nick Talley and the group, and Nick Talley had also had a full review in NEJM on role of duodenal eosinophilia and dyspepsia. The understanding is that in dyspepsia, the seat of pathology may be in the duodenum, not in the stomach. We keep searching for it in the stomach, but duodenum is a seat of digestion. Duodenum is a seat for the bicarb. Duodenum is a seat where there is this ongoing inflammation, interrupts the enterochromaffin cell signaling and interrupts all the hormone production. So people have found that there's increased permeability of duodenum, excess of eosinophils, and in this subgroup of patients, the feeling is that to look for food triggers in terms of allergies. If somebody has a problem with, say, any particular kind of food, peanuts, or any particular kind of food allergy. So I find what are the triggers in the patient. I try to ask them to avoid it for a week or two and see whether reintroduction results in recurrence of the symptoms. And this duodenal inflammation increases the sensitivity of the duodenum to acidification. So that triggers the symptoms. So duodenal healing is important. Regarding duodenal biopsy in a routine endoscopy, I do it whenever I find any abnormality visible on endoscopy. Whether we should biopsy a normal looking duodenum, I don't think so, but definitely an abnormal looking duodenum you should biopsy, and you should look for abnormality. I usually use NBI in the duodenum to pick up subtle abnormalities and take biopsies, and quite often we find chronic inflammation and increase IEL and celiac negative.
Absolutely. One thing is very clear that just go in and come out endoscopy is not this should be a strategy. Even for patient with dyspepsia, endoscopy should be like done properly. You should spend time looking at the lesion, looking at early gastric cancer, doing NBI, looking at duodenum. So need to spend time. Most of us sometimes just go in and come out. That's probably not the right strategy. And here is the change that we should learn to change practice, so that we provide adequate care to our patients. With this, I think we will have to close here. But before we do that, Dr. Raj Kumar from Bhubaneswar wrote that this was a crystal clear presentation. Absolutely fantastic. And I think all of us, Dr. Saraswat, Dr. Jayanti, and all the viewers, would like to say to you that it was a very clear presentation, simplified algorithms. That's wonderful. That all the algorithms which are very complicated, one-page algorithms on the textbook and review articles, but you fragmented them into small pieces and make things clear. More importantly, your algorithm on the principles of therapy, not only PPI or prokinetics. Once we call dyspepsia, it strikes our mind that we are talking about PPI and prokinetics, but we have more to do. If you do only PPI and prokinetics, the COSA showed that only 30 to 40% will get benefit, the rest will not get benefit. So we need to learn. I need to learn from the COSA that for this masterclass that there are much more to do. And I'm thinking of using sometimes antidepressants and other therapies. So it was a treat to watch and treat to listen to you, Dr. COSA, for a wonderful talk. And this is what the principles of ISG Masterclass, that we want to create some of the important concepts in medicine and change practice. With this, thank you, Dr. Jayanti, for very graciously joining the masterclass, and we are so happy to see you after such a long time.
Thank you very much.
Thank you, Dr. Saraswat, for always supporting masterclasses. Thank you, technical team. Thank you, Yogita. Thank you,
for the opportunity. And it was wonderful sharing my thoughts. In fact, last 1 month, I did a lot of reading, so it helped my understanding further, because I was just in the same state as most people. As we keep on reading, we learn more and more. So that is a very nice thing. And I'm also a part of the National Dyspepsia Task Force. So we are making this task force so that we can get better answers which are suitable for our country, and what anti-H. pylori therapy should be best for the country should be our next step. What is our resistance?
It's a major step, Usha, because without Indian data, we are generally following Asian, Western data and recommendations. And from the number of questions we have had about concerns about repeated courses of treatment and so on, there is great need for developing Indian data, and I think today we have the tools and the means to go ahead. And it's nice to know that you will be leading that task force, and you'll be part of gathering data, and hopefully we'll have objective evidence to base our recommendations on for such future master classes. Thank you, Usha.
So there are two things for the ISG task force. But Usha is the chairing this task force actively with Amit Datta. The two things that we need to have data on dyspepsia from our country. Then what is the role of exploratory treatment? What effect? And thirdly, we need to have our own guidelines on dyspepsia. So three tasks Dr. Usha is taking lead in. And before we close, we need to invite you for the one more masterclass next week, in the series of masterclass that is on next Sunday, that is June 7. The topic again is important clinical topic, that is how do you treat autoimmune liver disease. And this will be dealt by Dr. Salimar. Salimar is additional professor at All India Institute of Medical Sciences, New Delhi. And so we will have one next lecture on autoimmune liver disease on Sunday, June 7, 12 to 1. With this, we say bye-bye to you, and we'll see you on June 27 at our usual time, 12 to 1.
Thank you. Bye-bye.
Thank you very much.